Welcome everyone. I think we'll just wait a few minutes for a few extra people to join. I can see people are still joining now. That's good. Welcome everyone. We'll just wait another minute or so just to see if other people join, and then we'll kick off.
Hi.
Evening. Hello. How are you doing? We're just waiting for a few more people to join, and then we'll kick off properly.
Awesome. Brilliant. Thank you for organising this. It looks really good. Looking forward to it.
Yeah, it's a really interesting bunch of projects. We have got quite a tight agenda though, so I've been told by Jan to keep the intro as short as possible and crack on with the pictures, otherwise we'll be here after 8 and we need to get off and do our dinners and stuff. So I give it one more minute and then we'll kick off.
Awesome. Let me get my pen.
Right, well, we may as well kick off. But people can join us as they arrive. So welcome everyone to our first ever pitch event hosted by the Early Careers Group at the Faculty of Clinical Informatics. I'm James Maguire and I help chair the Early Careers Special Interest Group. I'm going to start by mentioning a few of the housekeeping rules. So please stay muted unless you're meant to be talking as part of a pitch, or we're inviting you for questions. And also the event, as you'll notice, has been recorded to be made available on the FCI website and YouTube, so just so you're aware. Firstly, thank you for choosing to join us this evening. It's good to see so many familiar faces and welcome to everyone who's new to the group. We're trying something different this evening. We wanted an opportunity to hear from a number of different members about the work they've been doing over the last 12 months. So we decided as a group that pitches would be a really interesting way to do that. The format of the session is going to be really fast paced. So I've got a timer ready to go in front of me, which I probably inevitably will stop. I'll press the wrong button, it will go off, but just bear with me on the technical side. So we've got 6 presenters ready to go who've been selected to speak about really interesting projects they've been up to over the last year. To make things a bit more challenging, we've asked them to cut their speaking down to 3 minutes. And then an extra 3 minutes afterwards for questions from the chat box. To keep things fair, we're going to be really strict with the timings, and after 3 minutes you'll hear and you'll be asked to stop, and then we'll go on to questions. We'll then ask you, the audience, to vote for your top 3 speakers via a link that will get shared in their chat box. And then we'll announce the winner at the end. The winner will receive the first ever FCI Rising Star Award and a certificate, which is great for CVs. So without further ado, we'll start the pitches. If you have any questions for the speakers or any other comments, just write them in the chat bar. Yeah, let's get going. So first up, we've got Pei-Fen. Are you ready to go? Let me know when you're ready to start.
I'm ready. Should I just click take control now, or?
Yeah.
Okay, right. Okay.
And ready to go when you are.
Yep, okay. So good evening. My name is Pei-Fen Lin. I'm a consultant ophthalmologist for the Cataract Service with Moorfields Eye Hospital with our satellite unit at Croydon. I'm passionate about anything digital or anything automatable, especially transforming eye services into a more sort of online style. The traditional pre-surgery assessment for cataract clinic involves face-to-face consultations. And for a patient, if you're very lucky, you spend 2-3 hours in the eye unit, hoping that everything is done in that sitting. And then you second time you come into hospital is the surgery day. And that's the traditional one-stop clinic. But reality is never that dreamy. So often patient will need to come back a second or third time for different scans and things like that. Cataract is the most commonly performed surgery in perhaps the world. I mean, in the UK alone, we perform about 400,000 a year. It is the most affected surgery from COVID because it is one of the most benign eye conditions, and it's reversible. If you went blind for a cataract, it's reversible. So we were the first service to be cancelled, the last service to be recovered. Now, in order to not face a terrible tsunami coming back from COVID, I piloted a digital service split the consultation part from the investigation part. And so far, we've seen about 250 patients and online. And so we split the consultation. I spent 20 minutes dedicated to talking to them about the surgery, about the cataract condition itself. If they decide to go for surgery, then we do the investigation. I then offline and then check on the investigation results, book them for surgery. So far, we've seen that the listing rate is just as good as a traditional face-to-face. The difference is that patients love it because instead of spending 4 hours, they spend 20 minutes dedicated time speaking to the doctor, which is the most time-consuming part and often the least spent on the day in a face-to-face setting. What happened? Then they spend 14 minutes for a scan to be done, and then the next time they come in, it's surgery. The harder group to convince is actually my colleagues who are desperately trying to go back to the traditional face-to-face pre-COVID norm, and I'm trying to convince that actually no, the data shows it is the right way to do things. So the future, I'm hoping, is bright. Pilot has demonstrated that iClinic can go online safely and very efficiently. There are many further opportunities to further automate steps in this pathway that we can actually see patients and actually spend the consultation time, to build a rapport, the explanation with the patient, and make them comfortable about the surgery itself. My dream is to have an ATM kind of thing in the wall. And if you feel you have an eye problem and cataract, you stick your head in the wall, it does all the scans, pops out a question saying, looks okay, come back next 6 months. Or, yeah, I think that cataract needs doing now, so do you want to speak to a doctor and discuss surgical options? And then the doctor can just see the patient and talk to them instead of all the boring stuff. And then, me sitting in the waiting room, waiting for 3 hours, 10 minutes for them to walk into my consultation room, 10 minutes for them to walk out, and I spend 3 minutes explaining what a cataract is. So that's the dream. I'm hoping to get some tips from the audience on how to bring things forward. Thank you.
Thank you very much. Kieran's asked a question. Do you want to just unmute yourself, Kieran?
Yes, happy to do so. I wanted to know what, if any, special software or systems were needed for you to adopt this kind of tele approach to ophthalmology, and how challenging would that be for other centres to adopt, and at what cost?
So at the moment we use Attend Anywhere, and that was in a program purchased by Moorfields for the emergency clinic consultation. It is not as good as Zoom, I'm ashamed to say, but it is GPDR, qualified, safe for transferring patient data and stuff like that. So it wasn't difficult for us to use it, but I suppose any online consultation platform would do. The next step that I'm looking for is actually cross-screen examination. I think that's the limiting factor. If we can move that online as well, or further into the community, so the patient at this point still needs to come in for machines that was only available in hospital to do so. But a lot of the opticians are purchasing these machines in the community. So I suppose if we can bring these machines to the community, or even if I can, if you have any ideas that I can do these scans for planning for surgery on the patient's phone, then that eliminates a big step. I think that's if technically we've demonstrated patients don't really need to spend that much time in clinic. So technology-wise, consultation is easy. So anything like Zoom, that's safe. Anything like Teams, that is safe. That is obeys the rules, then it's fine.
I think Anne-Marie also had a question about if there's any difference between people progressing to assessment to surgery.
Faster, actually. They're coming through faster because we don't have the funny sort of gap between consults. So sometimes in face-to-face, when I consult patient, they're like, oh, I want to have a think about it, or like they didn't show because they're worried about COVID, or they need another different scan, another consultant needs to speak to family. We are looking at the preliminary data, comparing the online group and the offline group, I suppose. Offline group tends to come through about 2 months from consultation to surgery date, and that's also building into the fact that we are catching up with backlogs. But the offline people comes through, the online people comes through about 4 weeks because they are confirmed and they have their scans. When they come in for their scans, they spend 40 minutes with the nurse and scan, and it's done. And I can check the scans, make sure everything is correct. The traditional one is a bit disjointed. So it's faster coming through the online way.
Great. Thank you very much. So next, we've got Sarju.
Okay.
Ready to go?
I think so. I'm ready. Yep.
Cool. Great. Time is started.
Hi, my name is Sarju Mehta. I'm a clinical geneticist, and as of 4 months ago, a Topol Digital Fellow. And my project is to try and identify more patients with genetic diseases in an automated fashion using our electronic health record, EPIC. So rare diseases, although individually rare, collectively they affect 1 in 17 of the population. And the majority do have a genetic basis. But traditionally, there's often been a long time to diagnose these patients, because of testing limitations and also because of under recognition of their symptoms. However, with the rapidly reducing cost of genome sequencing, this is a log scale on the y-axis, it is now relatively cheap to test and diagnose these patients. It's quick and it is also scalable. However, many of these patients do have quite non-specific symptoms. They're multisystemic symptoms. And so it's quite difficult for the clinician to identify these patients. And even then, many clinicians don't have the education and training to diagnose these patients. And the other issue has been that because of the rapidly evolving nature of genetic testing, it can be quite difficult to sort of navigate this arena. So what I'd like to do, what I'm trying to do, is leverage the current functionality within our electronic health record to actually identify patients using algorithms that I've already designed, using structured text field information such as either diagnoses or other searchable parameters such as growth parameters, imaging measurements, and biochemical values. And EPIC has this best practice alert system that I can utilize. So currently, when a patient is admitted to hospital, EPIC searches all the inpatient notes for predefined criteria that I've described, and it triggers on opening of that patient chart. That alert currently comes to me as an in-basket message, but there is the option to alert any healthcare professional who opens a chart, or probably more realistically, certain staff groups who may be interested in this. And then within the alert itself, I aim to give them some guidance, either to consider if genetic testing is appropriate with suggested sort of tests, or referral to us in clinical genetics. And then once the result is available, I aim to signpost the clinician to resources, both for themselves and the patient, on our website. Thank you.
Thanks very much. Any questions? I'll jump in then as the chair, as the prerogative. What are the next steps for the project then?
So I've built some of the alerts. Now the next step is really, so this is a new type of clinical pathway. You know, traditionally patients get sort of referred, and then someone has to think about a genetic condition. Here, someone, the computer is sort of telling you that, oh, this patient may have a genetic condition. So I'm actually trying to work with different clinical groups, so cardiologists, pediatric neurologists, working on 4 or 5 discrete conditions, see where this might fit in their pathway. And I'm also developing some resources to kind of guide them through the genetic testing pathway and the website resources that I've described.
Kieran, did you have a question?
So I have a couple of questions. First of all, how far through the deployment of this are you? Is this actually a live system yet?
It's live to me at the moment, yeah.
Okay, so what is the yield of this in terms of how many alerts does it yield, and those that have alerts, how many of those or what proportion of those turn out to have the conditions of interest?
Yeah, that's a really good question. So, I mean, it's been live for about a month now, and I've got 900 alerts in my, in basket. And so what I'm trying to do now is refine them a bit more, because, that would just, yeah, exactly. This issue of alert fatigue is prominent in my mind. And what I haven't gone through so far is, how many, we haven't tested any patients yet, so I don't know what proportion will actually have the conditions in question.
So can I just ask a follow-on question, which is this EPIC dependent, or is this EHR agnostic?
So the algorithm itself could be agnostic, but I don't know how some of the pathways that I've developed, the websites I've developed could be obviously scalable, but what I don't know is whether other EHRs can kind of do this thing. That's what I don't know.
Can I?
What, Anne-Marie, I was going to say, I saw your hand go up. I know I was on mute.
Yeah, sorry, I was just like trying to type, and I'd already kind of got my alert fatigue. For me, it's really interesting to see secondary care thinking about doing this sort of thing, because we've had coded data records in primary care for a lot longer, and that's where we're a lot thinking like, oh, how would that work? How would that work out? There's like things like, could this person have cancer? Might they have sepsis? And everybody, gets crazy about it because they don't seem to feel. And I'm just wondering, is there something about your population that makes it more likely that there will be a genetic condition there, or?
Well, these are only inpatients currently, although you could do all hospital, patients. But the parameters are set quite, just sort of kind of trying to get the, a tiny percentage of the group. So like, I don't know, hypertrophic cardiomyopathy, any, a septal thickness above 15 millimeters, for example. So kind of much more definite, criteria.
So it's actually that you're picking really objective sort of measures, which are structured data within the record, rather than being dependent on something. Yeah, interesting.
Yeah. I mean, it's a bit of both, some objective, but some just, diagnoses that people have made. But I'm trying to increase the sensitivity and specificity, essentially.
Great. Next, we've got Anna.
Hi, so I'm Anna, and I'm a clinical lecturer in child psychiatry. So this is Chris. He's 16, he's had low mood, and he's been anxious for 2 years. He sees the GP frequently for headaches, and now also his school nurse. His family have been seen by a social worker 6 months ago, as his younger brother was self-harming. He was discharged and is now on the CAMHS waiting list. His grandmother cared for both of them a lot, but has went to a care home, and now because of COVID, they haven't seen her for over a year. So things are really getting worse, and Chris is now not going to school as much as he should be, but no one has yet asked him if he's okay. If we could bring the data together from all of these touch points, and we could use it to spot patterns that would help us to identify problems like this, and enable us to ask Chris if he's okay and if he needs help. However, there are significant barriers at the moment to this, so we can't bring the data together that's required. We can't therefore build accurate AI models. We haven't got algorithms. We can't implement them. We don't know if it's acceptable to the public to use data like this, and there are significant issues of inequality. So we're creating a data environment that can tackle this. It'll have two parallel systems. One is identifiable for direct patient care, and this brings together data. This data is de-identified, and then we create a de-identified research environment in parallel. The algorithms are built in this de-identified environment and then implemented in the identical clinical environment. And these algorithms help us to identify young people at high risk of problems, and then a multi-agency team will be able to manage them. So we've secured ethics, and we're receiving data this month. Our database will include data on all people between 0 and 17 in Cambridge and Peterborough. It includes mental health, the acutes, community services, social care, early help, and the school data. Success has depended on effective partnership working. Oh, sorry, we go back. Gone forward by mistake. Success has depended on successful partnership working. So we've worked with the Anna Freud Centre to create a PPI group, and we've appointed Sophie, a young person, champion. We've got our first citizens jury in 3 weeks' time, and we'll be exploring in depth the issues and concerns around using data for predictive risk in AI, and the implications for mental health services for kids. We've also partnered with the system, and we've been committed to creating a data resource that can build capacity. So we've partnered with Intermine, which has created an accessible platform, which means that the services providing data can access their data and also access multi-agency data, which will be used for QI, population health, business intelligence, and audit and commissioning. So I'm now going to just pause and leave on this slide where you can see why it's important and why what we're doing really matters. Thank you.
I'm stuck on mute, sorry. Thank you very much, and to time. Any questions?
Sorry, me again. I've got a question, if that's all right. Although I'll let you see if anyone else has any questions first, because I've asked every time so far.
Go for it, and then other people can put their hands up.
So, are there any other similar data resources that exist elsewhere in the UK or abroad that could be used for external validation once you've built algorithms? And if not, how do you expect to be able to validate these adequately to deploy in the clinical setting?
Yeah, there's a range that are nearly similar. So SAIL is the most obvious one, so that's Wales, and they've brought together all data, and I think they're including the genetic data, which we'll also be including. Maudsley, they don't have acute data, but they have got a similar data set. Imperial actually has got another one, and then there's also Oxford are currently building one as well. So there's not an identical data set, but one of the ways we're approaching this is by partnering with another startup called BitFount, and it's a privacy preserving data sharing platform, which enables you to link to external data sources without the data actually being moved away from the organisation. So, for example, we could link into your data, data at Imperial or data at King's, and run our algorithms on those data sets, and the data sets that we'll be linking into don't need to actually be linked, so the platform can link the data using the same methods that we've developed for this data set. So the plan is to enable external validation using that where we are not able to have an identical data set, which it won't exist because no data set's identical. So that's our approach that we're going to take.
Thank you.
Any other questions? I mean, I was going to ask, obviously data sharing has been in the news over the last week or so. Have you, like the initial PPI engagement, have you had any kind of big concerns thrown up, or any barriers that you can see coming?
So I think that most of the people, so it's been really interesting actually, because people are really, once they understand what we're using data for, and also the fact that it's de-identified data, they're really supportive of it. I think the main concerns people get raised is because obviously we're bringing in school data, social care data, health data, mental health data. They're saying, oh, will the teachers be able to suddenly know what's happening at social care? So I think a big part of it has been around education and and kind of develop really clear communications about actually what data is being shared with whom, and making it clear that actually the only data that will ever be seen by anybody is by clinicians who are directly looking after the patients. But the researchers and other people will only ever be able to see de-identified data that doesn't relate to them specifically. So I think in that context, people feel much more comfortable. But I think we've found that there's a real, understandably, lack of knowledge and understanding about the different types of data and what they're used for, and so therefore obviously there's anxiety, and I think people in the profession are anxious about it, rightly as well. So yeah. So yeah.
Great, thanks. Thanks very much. I guess the next speaker is Nav.
Hi.
When you've taken over control, and I'll start the timer.
I've taken over control. Hello, my name's Dr. Nav Paul, and my talk today is about my research proposal based around my two favourite subjects, data and dermatology. I am a GPSI and trainee dermatologist and new member of the Faculty of Clinical Informatics and Shuri Network. So if you take home one message from my talk today, I hope it's this, and that is that high quality data is vital for the development of safe, accurate, unbiased digital health technology. Developments like AI can have significant potential benefits for healthcare provision. However, we know that this may not always be a reality. So let's take the Google DermAssist tool, for example. Although this is an exciting proposal, its algorithms have been trained on a narrow data set and therefore of limited benefit to people with darker skin types. In fact, multiple examples exist across dermatology demonstrating a lack of ethnic representation in research, educational resources, and product development. The pandemic's highlighted the disparities in outcomes across multiple parameters. For example, reduced accuracy of pulse oximeters and biometric technologies in people with darker skin types. So we can start to see the connection between people's skin colour, not just ethnicity, and their healthcare outcomes. One of the problems is that the clinical assessment tools used in dermatology are not appropriate for the purposes of creating data sets to build the technology in the first place. For example, the Fitzpatrick skin typing system used in the development of Google's DermAssist only ranges from 1 to 6 in terms of describing colour, and was actually designed as a phototyping system relating to the skin's ability to tan itself. So this is my point. If a cosmetic company can recognise that multiple skin colours exist and develop solutions for this, there's no reason why clinicians and informaticians cannot do the same. So we need our healthcare data to be all of these things listed. Well, maybe everything except biased. So globally, we're at a unique juncture in healthcare technology. And I believe that we need to act now to prevent further avoidable harm. So I hope to merge my interest and develop more inclusive skin categorization systems, in turn, which can be used to create metadata across healthcare and improve the systems that we develop, and therefore trust and credibility. So I want to bring together my unique perspective as a clinician and as a citizen to help deliver technology that will have real value for the future. Thank you.
Great, thanks.
Sorry, my slides kept...
It's okay, don't worry.
Stuck there.
I'll jump in with the first question. So I guess what's the next steps with the work? What's your plan going forward?
Yeah, so actually, I'm developing a research proposal around the importance of creating data sets that describe skin color for the purposes of developing health technology. So I'm in conversation with industry, academia, clinicians, and various people to try and put together a research proposal so that maybe I can get some funding to do this work that I think is really important. And maybe because of my background as a GP and dermatologist and clinician, I can see a way of connecting the dots, but I need sort of advice about where to go next and what to do.
Thanks. Does anyone? Oh, Kieran's put his hand up.
So the issue of underrepresentation of people from minority ethnic groups is a problem that's not just unique to data sets, but as you've highlighted, is actually a problem across a lot of research. What do you think people in research or database development could do in order to improve the representation of minority ethnic groups, no matter what the data set is about?
I think there might be two sort of points here. So my research is really based around skin color, which may or may not be related to people's ethnic groups in the way that we previously thought that it was. And that's an interesting angle in itself, because there are more and more people of mixed racial backgrounds, and they describe their ethnicities as different. So I think actually a qualitative type research study might be the first step that we might need to take to understand how people describe their skin and their ethnicities, and then see if there's a way of like matching that up, because I think this is the whole point. We may be missing a trick here. It may not just be ethnicity, it may be skin color and skin type, and then that might have other ramifications. Does that answer the question?
Yes, thank you.
Any other points? Any other questions? We'll move on. Patrik, I think you're all next.
Great, I've taken control.
Did you have a last hand? Oh, you're on mute.
Sorry. Did you have like people, I mean, globally around the world? Because obviously that feels to be like a way of getting to different groups. Is that the kind of network that you have, Nav?
Oh, yeah. So basically, I am in conversation with a couple of dermatology lesion recognition software developers in the States, as well as Australia. And I'm talking with a couple of groups in places like Africa and India, where they are actually trying to collate the data sets and take clinical pictures not only of skin problems, but also of skin signs of other sort of diseases. So yeah, the conversations have started, but it's really finding out what the research question is, of which there are multiple, and then finding out how to apply for funding, and then bringing all the bits together, really.
Okay, thank you.
Thank you.
Patrik, do you want to check?
James, may I confirm that this is transitioned to a black and white slide?
That's right.
Perfect. In which case, I think I should be ready to go. So good evening, everyone. I'm Patrik. I'm a clinical research fellow in digital health at Imperial College London, and I'm delighted to pitch to you my idea for reinventing the stethoscope using artificial intelligence. So many of us will be familiar with this tool, which since its invention over 200 years ago, fundamentally hasn't changed very much. So consisting of a bell or diaphragm connected to some tubing and then conducting some noise through some earpieces. So that's only really until recently, where through the convergence of cheaper, smaller and more powerful electronics, we now have access to digital stethoscopes that are able to transmit and visualize a variety of data signals from a variety of sensors. So this includes digital heart sounds and the single lead ECG. And so naturally, as the volume of these digital biomarkers accumulates, we've been able to generate new AI algorithms to predict a whole host of cardiovascular diseases. But importantly, in order to deploy this technology in a meaningful way that works for the end user, we can leverage interconnectivity, where the ECG and heart sound recorded at the point of care can be visualized in a smartphone. And critically, using a cloud-based portfolio of AI algorithms, we can detect a variety of cardiovascular diseases that are public health priorities. But the key challenge and resource requirement is actually to support the time and effort required to train, to test, and to extensively validate these algorithms in the real world. And so to demonstrate that this is an extremely worthwhile pursuit, I'm excited to be able to share with this audience recent results of a collaborative study that I've been leading on. So we recorded a single 15-second stethoscope ECG from 1,000 patients. And by analyzing the signal with an AI algorithm, we were able to detect heart failure with an impressive sensitivity and specificity that is far superior to many of the established national screening programs. And so this is a feat way beyond human capability. So I suspect nobody here on this call could look at a single lead or even a 12-lead ECG and confidently predict whether or not the patient has heart failure. And so on the basis of this proof of concept, I'm looking to reinvent this stethoscope examination as a touch point for comprehensive cardiovascular disease screening. And through additional funding and support, we should be able to develop further AI algorithms to detect not just heart failure, but other priority cardiovascular diseases. And this is all using a non-invasive 15-second point-of-care screening tool that takes a universal form factor that is used by all clinicians and is appropriate to be used in all patients. So I'd love to take feedback and any questions from the panel or the audience. Thank you.
Thank you. Any questions? My question was going to be, what with the heart failure? What's is it? PEF.
Yeah, so we're looking at an ejection fraction at or below 40%, since that's where all of the evidence for prognostically beneficial medications are. So the preserved and moderately reduced ejection fraction patients, unfortunately, we have no guideline-directed therapies for. So the algorithm is tuned to identify those where we could start therapy.
Tashmeen, you've written a question. Do you want to say it out loud, or shall I? And Kieran's got a hand up as well afterwards. So Tashmeen's asked whether it could be used to detect undiagnosed cardiomyopathy and sudden death syndrome in younger people.
Yes, so in fact, we are working on both of those algorithms. So it's just a matter of using the Imperial College Trust cardiology cohort, getting enough training data. The challenge really here is that we have a form factor that we want it to be easy to use by a non-specialist. So the beauty of single lead ECG kind of delivers that, but it's obviously much less granular than having a full 12-lead ECG. So far we've shown that you can export a 12-lead algorithm to single lead, but trying to do the same for cardiomyopathy and inherited conditions is something we're testing to see if actually a single lead is enough.
Interesting. And Kieran, did you have your hand up?
Yes, so two questions. So the first question is, what is the cohort that you have used in order to test this? And is this a representative cohort? And then the second thing is that given that this is based around, in part, single lead ECGs, is the stethoscope itself necessary, or are wearables such as single lead ECGs from an Apple Watch sufficient?
Great. Yeah, thank you. So to the first question, the algorithm we're using was trained on a predominantly white populations. So the Mayo Clinic has developed the first iteration that we're using. So that's 90% white Minnesotans. Our cohort, compared to the other external validation studies that have been done in similar ECG-based AI algorithms, is among the most diverse. So we have 41% non-white participants, which is an order of 4 times higher than comparable studies. And so within that, we have a very sort of diverse ethnic mix, and that's because we're based in North London and have some of the most diverse postcodes, both in Europe and I think the world. And the second point about other single lead ECGs, so the beauty of the form factor of the stethoscope is that it actually opportunistically captures 2 bits of data, not just the ECG, but also the heart sounds. So in a single examination, you can apply AI to both of those biomarkers and screen for several things. Whether or not the Apple Watch records an adequate single lead ECG, we can slightly extrapolate from having used the tool in a handheld setting. So we give the patients a stethoscope to hold in their hands, and we found that the ECG signal is not as good as it would be over, and specifically we found that over the pulmonary valve is the best position for the cleanest ECG with the highest rates of attempt at interpretation.
Can I just come back on your answer to the first question? Beyond ethnicity, in terms of things like disease burden, ill health, background, health issues, how are these people recruited, and are these kind of sick hospital patients that you're trialing on, or are they general background population?
Yeah, so both. So the way we needed a gold standard reference to be able to compare the performance of the algorithm, and so for heart failure, that's echocardiography derived ejection fraction. So we had an unselected recruitment process where any patient who was above 18 attending for an echo was approached to be a participant in the study. So we have a very broad group of patients. I mean, obviously there is a bit of self-selection that they are turning up for an echo, and as we know, sort of access to investigations or attending for these things is not as good in more deprived communities. But actually, the demographics that we have in terms of also their disease profile is far more diverse than other external validation studies.
Pei-Fen, did you have a question as well?
Yeah, so it's about whether because the project is about the stethoscope AI, so the important bit is about the sound. So have you considered applying to sort of respiratory diseases? So because like lung function type of things, or breath sounds and things like that.
Yeah, so I've just got a collaboration off the ground with Cambridge Acoustics Lab, who have this theory that the body has sounds that you can put it to someone's head and listen to their aneurysm throbbing away in the circle of Willis. They have, they think with machine learning you can basically auscultate your way to all sorts of diagnoses, and among that is the whole sort of portfolio of respiratory conditions. So yeah, absolutely.
Great. Next we have Ramandeep, who doesn't have slides. So I guess should we stop sharing the slides so we can see her?
Thank you, James. Good evening, everybody. My name is Ramandeep Kaur, and it is a pleasure to meet you all virtually. I'm the lead electronic prescribing and medicines administration, EPMA pharmacist, and interim EPMA project manager at Barking, Havering and Redbridge University Hospitals NHS Trust. I have over 6 years experience in the digital field with a specific focus on EPMA, and I'm passionate about digital health, innovation and medicine safety. Let me share my story. I'm a rheumatology patient and a clinician. In May 2020, my life changed due to COVID-19. Suddenly, I found myself having remote consultations for my condition and working from home as I shielded for 105 days over the year. EPMA was a saviour for me to do my job. Roll on a few months, and into August 2020, I moved cities and jobs, and transferring my care and gaining access to my prescriptions became a huge problem. So why does this matter? In my current trust, we use paper for both inpatient and outpatient prescribing, administration and medicines management processes. Paper processes can result in delays to treatment, missed medications and longer stays in hospital. Medicines expenditure constitutes over £46 million of the Trust's annual costs, and over 2,000 medication incidents are reported annually. These are stark figures. There is also no link between our hospital systems and my local GP, which makes obtaining right drugs at the right time a challenge. So what's my goal? To champion computerized charts and implement EPMA to 50 inpatient wards and our inpatient areas. This would be a huge stepping stone to improving the medicines management processes for our patients, allowing us to deliver excellent care and negate some of the problems associated with paper charts, and is a key enabler for delivering the objectives of a happy, healthier hospital. The deployment of an EPMA system will give the organisation greater opportunity to be agile, and the concepts of virtual clinics and remote working can be used to support the standardisation of excellent clinical practice and improve the experience for patients like myself in secondary care and bridge the gap with primary care. To date, there have been a number of challenges during this project, and these include COVID-19, redeployment, recruiting staff, and a lengthy procurement process. Despite this, the Trust are in formal procurement stage and plan to procure, design, build, configure and deploy an EPMA solution fully by December 2023. So finally, how can you help me? I have discovered recruiting staff for fixed-term posts a challenge. I would love to know if you have any advice for enticing individuals to join me on this exciting digital transformation journey and be part of the EPMA team who pride themselves on championing excellent patient care through the delivery of computerized charts. Thank you.
Thanks a lot. Anyone want to jump in? Any questions or advice? I was going to ask a question, which is, you've kind of touched on some of the benefits. I guess changing that sort of workflow for staff is quite a big upheaval. What are the benefits that you're expecting to see for staff?
So from my perspective, in terms of the staff benefits, I think we're doing a lot around benefits realisation and the time taken to conduct audits. So, for example, I sat in a VT task and finish group earlier this week, and they're all talking about going out and doing this manual audit collection, and there's this form. So that's just one of the things where actually having an electronic system in place would be brilliant, because if you can link that to the informatics and be able to get that data out to then show how to then make a difference to our patients, and actually to reduce that time for manual audit collection. So that would definitely be a plus for our staff. And also just having that ability to be able to do things remotely, and especially when we're in when we've got staff shortages, just like any of us who are on the front line will know, to be able to sort of do some of that work remotely and be able to utilize your staff in a much more be able to utilize the skills across the board of the staff would be great. So for example, if you had a student, you could say, actually, you can screen these virtually and then I can have a look at them. Just little, it sounds so little, but actually the benefit to our staff would be great, and to just stop using all this paper and to encourage people that we can do this, and that it isn't necessarily anything. I appreciate there's been some fantastic presentations this evening, but we're not necessarily doing anything that's pioneering per se. We are just trying to move ourselves along this journey and improve that experience for both staff and patients, and improve that digital literacy as well, which I think there's a huge gap there in terms of digital literacy in organisations. Anne-Marie,
I see you've got your hand up, and then Monica's got a question as well.
Just to say, Reinventing, there's a lot of work for us. We're doing a lot of work on this in Wales. We actually have getting a business case to approval, because at the moment in Wales, there's only one hospital that has EPMA and a few wards. And so there's a lot to be done about it. And I think it is a basic thing, and it's really good. I'm really glad that you're thinking about getting involved with the digital health panel and everything, because I think doing these sort of things that are the real kind of key enablers are really important. So if it would be lovely to actually see a kind of a peer learning group or something around the challenges of doing things like EPMA, just a special, a group that are sort of looking at that, because there must be a lot of experience to share.
There are so many pharmacists I speak to. There's a great community of really inspiring digital pharmacists that I'm sure you can get a lot of advice from. Pei-Fen, did you have a question? Sorry, I saw there was a few hands up, and you're the top name that's come up.
It's not really a question. It's just kind of from our experience of trying to introduce something new to the system. And Morpheo has tried several things to replace paper, and we found that you need to talk to the front end users why they held very tightly onto paper with their life, because I think paper has interoperability. So you flip the notes open, everything is there, scan is there, report is there, blood results is there, right? So, and I just need to add an entry, I take pen and I write stuff. But EPMA, it needs to interlink with something else. If it's not faster than me with a piece of paper on a prescription chart, you might need resistance. So if it's just from our experience, if you get the front people who's going to use your system first to participate in the design, there will be slightly less resistance. There will be haters, but there will be less haters.
They'll be the champions. I think the most junior doctors in the hospital do the most prescribing, and actually they're the ones in the middle of a night that don't want to run up 9 flights of stairs just to prescribe a dose of paracetamol. So it's they're normally quite quick converts over, and they've normally worked somewhere that's had e-prescribing. I know Tashvini had a question, and then Monica actually had the first question, which was what infrastructure do you need, if any, to implement this? And then Tashvini.
So in terms of infrastructure, I'd say for us as an organisation, we've got quite a bit of a challenge, I think, to get there. So we need a significant amount of equipment. So we did actually do some test drives last week with some of our frontline staff. And the first thing was like, oh, are we going to get extra computers? So actually there is a bit of work to be doing around, and also not just giving extra computers, but actually, are they going to take a drug trolley around and a computer around? So have you got the right equipment that's going to allow the staff to do the job? And I think for us, that's for me personally, that's really critical. But also something I've learned from previous EPMA roles is around Wi-Fi and ensuring the Wi-Fi connection is on point. I'm actually still at work and in an office, and I've literally got my speakerphone in my hand to make sure that the Wi-Fi doesn't drop out. And that's one of the things I'm going to be picking up with the IT department tomorrow, to make sure that we are thinking about that. So those are the definite infrastructure points, but also around closed loop medicines administration. So that's obviously something that is coming up in the sort of digital front, is something that we should all be aspiring to do in terms of organisations and through the HIMSS assessments. So actually, again, you need the right equipment to be able to deliver closed loop medicines administration. Oh, there's like.
Thanks very much.
It's not mine. I just
the baby.
I know.
Not me. I just wanted to say, just clinical safety in any IT systems that you're using, really, really important. With one of the places that I work, we've gone from being completely paper-based to being forced to become digital over COVID, which has now resulted in having to log into 5 different systems to be able just to access a patient's notes, to be able to plan their treatment for that day. And I feel it's increased risk massively, to the degree that you could be doing the wrong treatment or prescribing the wrong drug. So I think clinical safety, definitely something that your clinicians, whoever's going to be part of the project, needs to be aware of it and really, really champion that cause, because it's like essential.
Thank you for the comments.
Right, so Shalane's just dropped the link to vote in the chat. And now it's over to you lot to cast your votes. So what I'm going to suggest is, whilst people are voting, I open the floor to the people who pitched and ask them how it was, what was challenging about pitching, would you do it again? Floor is open to the people who are pitching.
I'm just saying, presumably we were not allowed to vote for yourself, I'm guessing.
You are allowed to vote for yourself.
Oh, really?
I haven't set any rules around it, so if you want to, then it might be the best way to gear it.
I just have something to say. I absolutely loved Ramandeep's pitch and presentation, and when my slides were getting stuck and my Wi-Fi or something was dropping, I was like, okay, I hear you, sister.
Infrastructure.
So, something to learn from. Fancy slides don't always help. But yeah, that it did get a bit stuck, but still amazing. The whole group, amazing. I'm just really pleased to be part of this. Thank you.
Thank you, Nav, for that comment.
So I was worried that it was going to be, so I was saying before to Shalane, it was going to be really baking hot like it was yesterday, and no one would want to turn up, but luckily we've picked an evening which is slightly less warm, well, less sunny at least, so it doesn't feel so bad staying inside for a little while.
I think it may depend where you are in the country, James.
True. Very London-centric. Apologies. I don't know whether last 30 seconds of voting, if everyone can, the form's fairly short.
I just want to say that I think all the projects that you guys are working on are brilliant, and I really hope that each one of you can progress them and just make real digital change to digital health. Definitely.
And we had a baby on the call, which is probably the youngest person that's been on one of our webinars to date. So hopefully there'll be an early career informatician at some point soon.
That's okay. I thought Lindsay's baby was going to answer my question about infrastructure.
So, Shalane, should we finish voting?
Yes, I'll close it now and I'll send you the results.
So I'll wait for the email to come through. So what did people think about the format? It's something. It was actually Kieran's idea a while ago. It was we thought we wanted to give people an opportunity after the last crazy 18 months to kind of pitch some of the interesting stuff they've been doing. But obviously keeping it short meant that we could get more people into a set time. And I guess it pushes you under a bit of pressure to kind of get to the nuts and bolts of what you're doing.
I enjoyed it. I thought it was good. And as you say, if you have to focus, just to the key bits of information, and I enjoyed listening to all the presentations.
Good hearing about the breadth of everything that's kind of going on as well.
Yeah, informatics is such a broad specialty and touches into like quality improvement and a lot of the data stuff that I don't really understand as much, but it's interesting to see what everyone's up to. Shalane, tell me when you've sent it through and then I will.
I thought they were brilliant as well. It struck me that it would be nice to kind of get a little bit of like summaries or something and put them on Discourse or something. I'm just thinking about a way of trying to access what you pitched has been really good, of accessing wider sort of network. Have any of you done that yet, or would you feel that was a bit too nerve-wracking? Because we could all come in and post and say that's brilliant. Why?
And actually, there's the digital summer school coming up and some of the other events, whether we can have a chat with Jan afterwards about how we can kind of link in with some of that stuff, because that'd be an interesting thought. So I've got the winner in. I don't know, we can't really have a virtual drum roll because there's no drum, but congratulations to Patrik. He has won the first award.
Thank you.
Anything, Patrik?
I mean, I suspect this would be the case for most people, but I've never won anything in this medium before, so I'm slightly overwhelmed and not entirely sure what to say other than thank you to everyone. I've really enjoyed the experience and really echo all of the comments that have been made.
Well, it's our first ever pitch event, so yeah, you get that accolade as well. It's the first time we've done this virtually or in real life, so maybe we'll have to bring you to the next one that we do either in real life or virtually to kind of hand on the award to the next person.
It'd be an honour and a privilege. I'd love to.
So as I said, this is the first event we've done. I think, Shalane, you're going to post another link in the note. Are you planning to do another one in the chat to get some feedback around how it went and whether we could improve it further going forward, which I'm sure we could. Lastly, just to say thank you to everyone who came to speak, everyone who came to watch, and the FCI team who helped to organise the event. So thank you all for taking the time out of your evenings. We hope to see you again soon for another event.
Thank you. Take care, everyone.
Thanks, everyone.
Thank you.
Thank you.
Thanks.
Bye.
Thank you.